for this kind introduction. And I must say I'm really excited that we can conclude this nice congress with a session on cardiorespiratory physiology. That's really nice. And thank you for bearing with us until the end. Critically ill patients in our ICUs, they often suffer from circulatory shock. And circulatory shock, that is basically the lack of adequate oxygen supply to the tissue. And we have heard now a lot about how the oxygen gets from the lungs into the circulation. We have heard about the function of the heart, which pumps the blood into the large vessels. And from there, it goes into the tissue. The tissue is where the red blood cells in single file move through the capillaries, and the oxygen diffuses from the red blood cells to the target cells to enable oxidative phosphorylation in the mitochondria. So that's of course, how the circulatory system works. But the question is, where happens the adaptation of our body to hypoxia? So in the critically ill patients, tissue hypoxia is the problem. How do these components of the circulatory system adapt to tissue hypoxia? And of course, there are a lot of data on the circulatory system adapting to the lack of oxygen. We know, for example, for the pulmonary circulation, of course, the pulmonary circulation reacts to alveolar hypoxia with the Euler-Lilja strand mechanism with an increase in pulmonary pressure. And if we prolong the exposure, and this we have shown in a study made on the Jungfraujoch, that there is early remodeling of the pulmonary circulation that keeps the pressure high. So if people remain within hypoxic conditions, this increase in pulmonary artery pressure, it will remain constant. Regarding the systemic circulation, and this is actually where the magic should happen to adapt to hypoxia, that is transmitted from the environment to the lung, or could originate in the lung in case of lung injury, of course. The pattern is much less consistent. For example, studies where healthy volunteers have been subjected to hypoxia, they show an increase in cardiac output, some show a decrease in cardiac output. It is really inconsistent, so there is no clear pattern of what happens. And similar to what we do in the ICU, we are measuring cardiac output, blood pressure, and the volumes in the heart and in the vessels to assess what happens with tissue oxygenation. This is really a challenge where maybe we should be looking actually at the tissue and the mechanisms that regulate the blood flow in the tissue. So is there an adaptive response to tissue hypoxia that is an intrinsic function of the microcirculation? So that would be the question that I would ask. And then the second challenge, of course, is we cannot really examine the mechanisms of adaptation that physiologically happen to tissue hypoxia in critically ill patients, because they are much too heterogeneous. There are so many factors influencing patients with ARDS, with sepsis, that we're not able to study the physiological mechanisms. So we need a model for tissue hypoxia, for isolated tissue hypoxia. And that, fortunately, is very easy to find, because we happen to live on a planet with an atmosphere that gets thinner as we go higher. So there is a clear and easy relationship between the altitude above sea level and the atmospheric pressure, which also defines, of course, the partial pressure of oxygen that we can breathe in to the lungs, and in the end, the oxygen supply that we can give to the cells. There have been a lot of exciting studies early on to study how does the circulation adapt, the microcirculation adapt to hypoxia. And they have been performed using this model of isolated tissue hypoxia at high altitude by bringing healthy volunteers to high altitude. So in the 70s, it was postulated that there is an increase in capillary density as a response to hypoxic exposure, but this was measured in muscle biopsies. So we took some samples from the muscle, looked at that under the microscope, and of course, there is a question remaining. is it really a change in density, or is it also just a change in muscle volume that would influence our measurements? So it was not really clear if we were seeing actually an adaptation mechanism. And also beyond the capillaries, there is very nice data, for example, on the increase in mitochondrial volume density happening in muscle tissue. And that, again, is a study that we performed in the Jungfrau Joch with muscle biopsies. But there we can really show that the volume density increases, so it's not a confounded effect. But nowadays, fortunately, we don't have to take muscle biopsies to measure what happens to the red blood cell flow in the tissue. So we can use in vivo capillary microscopy, where we indirectly light the tissue with green light, which is absorbed by hemoglobin, and then use dark field microscopy to show the movement of the red blood cells in the tissue. And the sublingual area, the sublingual mucosa, presents a very nice point where we can measure this in healthy volunteers or in patients in vivo. And you see in the images, you can see the individual red blood cells moving through the capillaries. And of course, the challenge here is we have very complex image data. And to extract the actual quantitative measures of oxygen delivery to the tissue from these images, it's not very easy. I won't go into detail here, but we have developed an algorithm that's able to analyze automatically these image sequences and determine independently and quantitatively the microcirculatory diffusion capacity, which consists on the capillary density and the capillary hematocrit, and also the parameters of microcirculatory convection capacity, so the movement of red blood cells, or simplified, the red blood cell velocity. And there is one more trick that we would need to use to discern these mechanisms in healthy volunteers when we then go to high altitude. And that is the fact that in normal people like we are in this room, only a small proportion of the capillaries that exist are actually perfused by red blood cells. So there is a pretty large reserve capacity, and these capillaries, they are perfused, of course, by blood plasma, but not by red blood cells. And there is a way that we also described how to measure this reserve capacity. It's actually quite easy. We can apply nitroglycerin topically to the sublingual mucosa and measure before and after. And this challenge allows to recruit the full capacity of the microcirculation. And by measuring after performing this challenge, we can look at the difference. And then we see the recruitable reserve capacity of the microcirculation. It's also, of course, a non-invasive measurement. So now we have the tools we need. We can actually take our healthy volunteers to the Himalaya, which is, there is a research expedition we have performed to Nepal at 7,200 meters, where we took 40 healthy volunteers to high altitude with the goal to measure in the sublingual microcirculation the blood flow. And of course, there are some very nice upsides to performing this kind of study. It's probably one of the laboratories I have worked with the nicest views ever. This is Camp 3 on Mount Himlung Himal at 7,000 meters, where we had the research tent to perform the measurements, the sublingual measurements. This image shows how the measurements are performed sublingually, and this is, of course, an image of base camp at 5,000 meters. There we still had the nice beds for the volunteers to lie on. In Camp 3, this looked a bit differently. And some things, they happen as a surprise in these environments. Here, the solution of the nitroglycerin froze, but it was, of course, pretty easy to remedy this this problem. And again, the reward, of course, to be in such an environment is enormous. So what did we find? And this is pretty nice. We had echo to measure cardiac output. We could calculate systemic vascular hindrance. This takes into account the viscosity of the blood, changes in viscosity. And our study was one of those studies where cardiac output decreased significantly, going from sea level to 6,000 meters. So as I said, this is really, if you look at the literature, in some studies there is no change, in some studies there is a slight increase. I think this depends on many factors. If you're outside, including your drinking habits and the amount of exercise that you've done. But obviously, this is not how the body regulates its oxygen supply to the tissue. So we look directly at the tissue, and there it, of course, gets interesting. Here on the y-axis, we have the total vessel density. This is the density of capillaries per volume of tissue that are recruited. And we see this here with on sea level to the left and on 6,000 meters to the right. And what is really interesting, we have performed the nitroglycerin challenge at sea level, and the amount of recruitment that was possible of total vessel density at sea level, it was exactly the same as was recruited when the volunteers went from sea level to 6,000 meters. So this shows not only that an important mechanism to increase oxygen availability in the tissue at high altitude in healthy volunteers is the recruitment of capillaries, the increase in capillary density, but also that this recruitment is a recruitment of already existing capillaries. So it's a functional recruitment. It's not a existence of new capillaries. This is how it looks like at baseline and nitroglycerin status, and at sea level and at high altitude. And you see that this here at sea level with nitroglycerin and baseline at high altitude is also in the detailed analysis is a consistent picture. Going a bit higher, so here we have the 6,000 meter measurements which we talked about, and then going higher to 7,000 meters. You have seen the images of Camp 3. There is another aspect coming up, and that is that the total recruitable capacity with nitroglycerin was actually higher than in the other two measurements. So there are two factors. One is that, of course, we spent more time until we did the measurements at 7,000 meters, so it was 4 weeks instead of 2 weeks. And also there was an additional stimulus of the increased altitude. And this might have led to really an additional number of capillaries being grown in the volunteers. So to finish, I would just make one comparison, again going back to the intensive care unit. And this you remember very well. This is for Switzerland, where I'm coming from, the COVID pandemic. We thought that basically COVID-19, it would induce an inflammatory state, which it of course did, and it would impair the microcirculatory function such as sepsis does, in the same way as sepsis does. So we wanted to see this in the microcirculation. We measured the systemic microcirculation using the same technique in our COVID patients, and we pooled the data with 3 centers in Switzerland and in the Netherlands to perform the analysis. So what we have found, and first we thought that there was something wrong with the algorithm. What we have found for all of the functional parameters of the microcirculation was an increase in functionality as compared to healthy volunteers. This was true for the vessel density, it was true for the red blood cell velocity, and also for the capillary hematocrit. So all of these determinants of convection and diffusion capacity went up. So this is not the picture of an impaired systemic microcirculation as we see in sepsis. This is the picture that looks exactly like we have seen in the Himalayas of a systemic microcirculation that adapts to hypoxemia, that here in these patients obviously comes from the lung damage and not from the high altitude. Just as a side note, this is a mechanism that disappeared in patients that had a SOFA score higher than 10. So of course these adaptation, these regulation mechanisms that seem to be intact in the COVID patients, they fail when those patients go into multi-organ failure. So this is just, I think, a very nice example, and maybe also one of the first such direct examples to show that really this model for tissue hypoxia going to high altitude is really relevant and directly connected to what happens in our patients in the ICU. So to conclude, the microcirculation has intrinsic regulation mechanisms to regulate oxygen supply to the tissue, and the response is to increase capillary density by recruiting capillaries. So it's capillaries that are functionally recruited as opposed to a structural response in the acute setting. And when you stay longer at high altitude and have a very extreme, let's say, stimulus, then neogenesis seems to be possible. And in critically ill COVID-19 patients, this same mechanism was described in the ICU in patients that were not in multi-organ failure. So providing a link between high-altitude research and critical illness. We are, again, performing research at high altitude. So a follow-up study that we have done at Mount Ahmad Ablam, just in November 2022, we looked at if intermittent hypoxia provided in a nitrogen concentrator tent would also lead to the same physiological response. And I will be happy to provide you with the results at a later time. Thank you for your attention.